Good morning, everyone. Today's topic is on spondyloarthropathies. Our eminent speaker is Dr. Shashank Akerkar. Shashank is the Honorary Secretary of Maharashtra Rheumatology Association, and he has set up a support group for patients with ankylosing spondylitis through his activity Stand for AS. Over to you, Shashank.
Thank you. Good morning, everybody. Great to be speaking to all of you today on a topic that is quite close to my mind, ankylosing spondylitis. Let me share my screen. I hope everything is visible to all of you, the screen.
Yeah, it's visible.
Thank you. So today, let's have a look at the group seronegative spondyloarthritis. Now, first of all, why is it called as seronegative spondyloarthritis? One, it is called as seronegative spondyloarthritis because it is the various ailments that are included in this group. In them, the rheumatoid factor is negative as against rheumatoid arthritis. So this is called as seronegative. And spondyloarthritis. Now, what all characteristic keep this an individual distinct group? One is association with HLA-B27, and second, involvement of the sacroiliac joint or the axial skeleton. What are the different types of arthritis that are grouped in seronegative spondyloarthritis group? One, ankylosing spondylitis, something that all of you, I'm sure, must have seen on a regular basis. Psoriatic arthritis, inflammatory bowel disease related arthritis, reactive arthritis, and undifferentiated spondyloarthritis. These are the different types of arthritis that are included in this group. Now, how will this group manifest? I'm sure you must have seen quite a patients with rheumatoid, possibly less patients of seronegative spondyloarthritis as compared to rheumatoid. So, how do we diagnose? What do these patients present to us with? One, they can present to us with axial involvement. What is axial involvement? We'll definitely see. Second, peripheral involvement. Axial involvement would mean involvement of the joints of the axial skeleton. Peripheral involvement would mean joints of the peripheral skeleton. And thirdly, other features. We'll have a look at each one in detail. Now, what is axial involvement? As you can see, this is axial involvement of seronegative spondyloarthritis. So, what is axial involvement? First of all, we should understand what is the axial skeleton. So, this you can see the skull, the entire vertebrae, all cervical, thoracic, lumbar vertebrae, and the sacrum along with the sacroiliac joint and the entire rib cage. This is what is called as the axial skeleton. So, inflammation of either the cervical, thoracic, or the lumbar vertebrae, those joints, or the sacroiliac joint. This is exactly what is axial involvement of seronegative spondyloarthritis. So, anybody coming with inflammation of this will present with backache or buttock or rib cage pain, or at times chest pain, because even the sternum and the sternoclavicular joints, those are also a part of the axial skeleton. So this is how a patient will present if he has axial involvement of seronegative spondyloarthritis. Second is peripheral arthritis, peripheral involvement. Peripheral involvement would mean knee, ankle, toe joints, hand joint. This is the peripheral involvement of the peripheral joints of SpA. Now, how do we differentiate? This is the typical pattern of presentation of rheumatoid arthritis, bilaterally symmetrical, small as well as large joints. When it comes to SpA, if you just look at the peripheral joints, forget about the axial skeleton, but the peripheral joints as against rheumatoid, what this involves is asymmetric joint involvement, large joints more than the small joints. So this is how, even when you see a patient who does not have axial involvement, just the peripheral skeleton, peripheral joint involvement, this is how you differentiate it from rheumatoid arthritis. In addition, obviously, the patient may have involvement of the axial skeleton also. So if a patient comes to you with polyarthritis, if this is the pattern, bilaterally symmetrical, small as well as large joints, no backache, then it is very likely to be rheumatoid or CTD. The spinal involvement, only vertebral involvement in rheumatoid is occasional involvement of the cervical spine. The rest of the spine is not involved in rheumatoid arthritis. And cervical spine also, atlantoaxial dislocation, is not something which is common, and not something which is common in the early phase. It's generally in the late phase of rheumatoid, chronic deforming phase of rheumatoid, that this will be involved. So the moment you see something which is axial involvement, inflammatory involvement, and again peripheral joints which is in this distribution and pattern, start thinking in terms of seronegative spondyloarthritis. So, how will a patient with SpA present to you? Axial involvement, or predominantly peripheral joint involvement, or a combination of axial as well as peripheral joint involvement. So, how do we go as far as history is concerned? If somebody has joint pain, obviously ODP, then you start thinking about which joints are involved, what is the pattern of involvement. Is it symmetric large small joint equal involvement like rheumatoid, or is it something that I told you, peripheral joints that are asymmetric, large more than small? That pattern will give you a clue to the diagnosis. And obviously, is it just joint pain or is there swelling also? Because swelling has to be there when there is inflammation. As far as axial skeleton is involvement, you may not get any history of swelling because these are deep seated joints. Peripheral joints, apart from joint pain, you should definitely look for whether there is swelling in the joints. When it comes to backache, the patients who present with axial involvement will complain of backache, and it is important to see whether there is this backache is mechanical backache or inflammatory backache. Inflammatory backache is the characteristic of axial involvement of spondyloarthritis. How do we differentiate that? Will definitely come in the upcoming slides. And lastly, you should not forget in the history about the other features of spondyloarthritis. What are the other features? Inflammatory bowel disease. We just saw inflammatory bowel disease related arthritis also falls in this group. So you have to look for history suggestive of inflammatory bowel disease, which will include recurrent loose motions, abdominal pain, mucus in stools, and at times blood in stools. Psoriasis, wherever, it could be any region of psoriasis. uh, Dandruff to some extent, history suggestive of dandruff, that could be psoriasis, the patient may be calling it as dandruff. Any history of red eye, because uveitis is common in this group. Any history of swollen fingers, swollen toes, this is suggestive of dactylitis, history based, this is how you can get it. And any painful points in the body, this is something that can suggest enthesitis. So now let us understand, if somebody comes with backache, how do you know whether this backache is because of seronegative spondyloarthritis? How do you come to know? There are n number of backache patients coming to the clinic. So this backache is called as inflammatory backache. Now, why is this called as inflammatory backache? This backache is because of inflammation in the sacroiliac joints. In seronegative spondyloarthritis, there is inflammation in the sacroiliac joints and the vertebral joints. This inflammation causes cytokines to be pent up in this area, and that is what causes pain. So this is called as inflammatory backache. Patient may have back pain in the entire back. At times it can be cervical, at times it can be thoracic, at times it can be lumbar. It can shift from one location to the other. And second most important is gluteal pain, particularly alternating gluteal pain, because this is something that directly correlates with sacroiliac joint inflammations. Now, how do we differentiate? See, the backache will have mechanical causes as well, something like a prolapsed disc, spondylolisthesis, radicular pain. How do we differentiate backache of ankylosing spondylitis or seronegative spondyloarthritis from that of mechanical cause backache? Inflammatory backache, the backache of SpA, is generally the age of onset is less than 40 years, duration more than 3 months, insidious onset. It is associated with significant morning stiffness, 30 minutes to 1 hour. A person with mechanical backache generally does not have significant morning stiffness. It can be, if at all, one, it may not be there, or even if it is there, it can be there for 5 minutes, 10 minutes, not something in the range of 30 minutes, 1 hour. Now, why does this morning stiffness really occur in inflammatory backache also and the other arthritis patients also? Why? What is the cause of inflammatory, the morning stiffness? What happens is, because of inflammation in the sacroiliac joints, a lot of cytokines are generated in the local circulation around the sacroiliac joints. When a person goes to sleep, because there is no movement, the blood circulation in the local SI joint area, back, the entire back, the SI joint area goes down. Because the blood circulation goes down, the cytokines that are generated get pent up locally in the circulation. So this is what causes a lot of pain and stiffness early in the morning, because these cytokines keep getting pent up in the local circulation and they cause pain. Once a person gets up, once he starts moving around, the blood circulation increases, it washes away the cytokines from the sacroiliac joint and the vertebral areas, and that is how then the morning stiffness, the pain stiffness goes down. So this is what makes morning stiffness extremely important in diagnosing inflammatory backache. This pain, inflammatory back pain, improves with exercise. The same reason that I told you, the cytokines get, when one exercises, blood supply improves, blood supply washes away the cytokines, and that is how there is improvement as far as the pain is concerned. Second important, very important, is pain at night, nocturnal pain with improvement upon getting up. And it is not just pain in night. See, there are patients who would say, I have pain at night. There is so much of pain, I just can't fall asleep. That is not suggestive of inflammatory backache. That can be functional. It could be n number of other reasons. Patient can sleep, he goes to sleep, but wakes up particularly in the second half of sleep, that is 4 o'clock, 5 o'clock, purely because of pain. This is exactly which is very classical of inflammatory backache for the reasons that I told you. So patients would give you history, 4 बजे 5 बजे नींद खुल जाती है और उसके बाद इतना दर्द होता है कि I just can't go back to sleep. I have to sleep like this in a chair after 4 o'clock, 5 o'clock. This is something very classical of inflammatory backache. In inflammatory backache, rest worsens the pain and exercise movement improves the pain. This is exactly opposite to that of mechanical backache. In mechanical backache, whenever somebody rests, the pain improves because it is of mechanical origin. And whenever there is movement, some activity, pain worsens, because in mechanical, there is a mechanical component which worsens the pain on activity. So this is how you differentiate inflammatory backache from mechanical backache. A few questions that you remember when you are taking history of the patient to get this exact history of inflammatory backache. Does the backache disturb your sleep? Again, very important when you ask this question. नींद आने में तकलीफ होती है क्या? नींद तो लग जाती है लेकिन रात में खुल जाती है दर्द की वजह से. That is very important. Difficult falling asleep is a different thing. That is not suggestive of inflammatory backache. But once the patient falls asleep and then he gets up because there is pain, backache disturbing his sleep midway, that is suggestive of inflammatory backache. Do you find it difficult to turn in bed while asleep? रात को एक बार सो गए, करवट बदलने में क्या दर्द होता है, नींद खुलती है, that is suggestive of inflammatory backache for the reasons we just discussed. Morning stiffness, there's so many times patient will not understand the meaning of morning stiffness. So what you can ask is, can you bend down to pick up objects once you get up in the morning? And that is how they tell you, first half an hour I'm just not able to do that. And lastly, how do you get up in the morning? Now a normal person would say he just gets up in the morning, starts moving around. A person with ankylosing spondylitis will tell you, अरे क्या बोलूँ, 10 मिनट लगते हैं, 15 मिनट लगते हैं, इधर पकड़ना पड़ता है, उधर पकड़ना पड़ता है, बहुत दर्द होता है, टर्न करता हूँ, फिर 2 मिनट बैठता हूँ, फिर उठता हूँ, फिर 2 मिनट बैठता हूँ, सपोर्ट लेता हूँ. So that is the classical history which suggests morning stiffness, because many of our patients don't understand the concept of morning stiffness, and these are the questions that you should be asking to get the definitive history of inflammatory backache. So finally, how do we differentiate inflammatory backache and mechanical backache? As I said, morning stiffness, very, very important. Inflammatory backache, it can be, generally we say, more than 30 minutes, but something more than 1 hour is very significant. Mechanical backache, it would be less than half an hour. Inflammatory backache is associated with significant fatigue. Why is the fatigue? Is the cytokines that are generated there that get circulated in the overall circulation that cause significant fatigue. In mechanical backache, there is no reason why one should end up with fatigue. So mechanical backache, no fatigue. Inflammatory backache, definitely fatigue. Activity improves the symptoms in inflammatory, worsens the symptoms in mechanical. Rest worsens the symptoms in inflammatory, improves the symptoms in mechanical. And systemic involvement like uveitis would be expected with inflammatory backache. Definitely not there with mechanical backache. So a person coming with spondyloarthritis, don't forget, whenever a person says backache, first and foremost, you'll differentiate whether there is inflammatory or mechanical. And second, start looking for other features. Is there any sign of arthritis? Is there any sign of uveitis history or examination? Uveitis, IBD, dactylitis, enthesitis. We'll have a look at those features also. And where does this backache, inflammatory backache, though it says backache, where all, which all regions can it involve? Cervical, thoracic, lumbar, most important, sacroiliac. In the front, it can also involve the hip and the inguinal area. Most important, don't forget the chest and the rib cage. Very common area. Chip, rib cage, in fact, is one of the common areas when it comes to ankylosing spondylitis. Why does this rib cage pain happen? Is in between the ribs, there are intercostal muscles. These intercostal muscles, they end up with enthesitis because of ankylosing spondylitis, and diaphragm attachment also ends up with enthesitis, and that is what makes this painful. Uh, the ribs also have a joint with the vertebrae, and that also tends to get involved. So from the posterior part, this inflammation can cause pain, and anterior part, inflammation, enthesitis of the intercostal muscles, in enthesitis of the diaphragm causes pain in the ribcage area. We have already seen now the axial component, peripheral component we briefly discussed to begin with. It how do we differentiate it from rheumatoid? It involves mainly lower limb joints more than the upper limb joints, large joints more than the small joints, and it is asymmetrical. This is how you differentiate pattern wise SPA from rheumatoid arthritis. Now let's have a look at specific features of SPA which you will not get in rheumatoid arthritis. There's something called as dactylitis. What exactly is dactylitis? See, if you look at these three toes and compare them with this, they are definitely swollen. Particularly this, if you see, it's definitely swollen. And it's not a particular joint of the toe that is swollen, but it's the entire toe that is swollen. This exactly is called as dactylitis. Dactylitis does not, it is inflammation of the entire soft tissue. This is also called as sausage digit or sausage toes. It is not inflammation of a particular joint. It is inflammation of, it is tenosynovitis of, and inflammation of the entire soft tissue of the toes, not a particular joint. And this is what this differentiates it from single joint. There's something like PIP joint involvement, PIP inflammation, MCP inflammation, DIP is the entire finger that swells up. See this. Now you can differentiate, make out even better. The entire toe is inflamed. It's not a single joint of the toe, but the entire toe that is inflamed. This is one more patient. What all can you see in this? See, this is tenosynovitis, psoriatic lesions, and this is enthesitis. See, compare it with this to this. What is enthesitis? Enthesis is an area where a muscle, ligament, or a tendon attaches itself to a bone. So this is the Achilles tendon attaching itself to the calcaneum. This is the area, and this has got inflamed. This is called as enthesitis. We have multiple entheses in the body. See, this is what is happening here. What you can see here is the tenosynovitis. This, what you can see here is the enthesitis. This Achilles tendon getting inserted into the calcaneum. This is what is getting inflamed. So this is what is the other common feature of spondyloarthritis, enthesitis. These are the different entheses in the body. So a patient, if he complains apart from visible inflammation of the joints, if the patient is complaining about other painful areas, this is what, this can be enthesitis. So touch those areas and see if they are painful. Common sites: one, Achilles enthesitis; second, the elbow. One more thing that is very common is heel pain, because it is again an enthesial area, and that is something again can get painful. Again, these patients can also show you other areas of pain, something like this patient. He keeps complaining of knee pain. As you see, the knee is not inflamed. You can see a swelling here. See, you can see a swelling here. You can see a swelling here. What is this? This is all enthesitis. Enthesitis of these muscles, peroneus muscles. This is where they get attached. And this is the patellar tendon. So all these areas are inflamed, as you can see here. So this is enthesitis. So when you look at spondyloarthritis patient, don't forget to look for dactylitis. Don't forget to look for and ask for enthesitis. Heel pain, again, as I said, it is plantar fascia enthesitis. So this is again a part of enthesitis only. What are the other features? uveitis, alternating buttock. See, when you ask the history of back pain, be very specific about asking for gluteal pain, one gluteal pain, and second whether it is alternating. What do you mean by alternating gluteal pain? Patient will tell you, पहले राइट बटक में दर्द होता था, क्या मालूम 6 महीने पहले राइट में था, अभी लेफ्ट में आ गया. So this is alternating buttock pain, clearly showing that it is inflammatory. At times there is inflammation in the right, at times it is inflammation in the left sacroiliac joint. Positive family history, very important. History of IBD, asymmetric arthritis, and raised ESR-CR. So this is how the algorithm works. Somebody coming with just chronic low back pain, just 5% chance of it being SpA. If you are clear that this is inflammatory, the probability increases to 14%. Then you look for specific features, enthesitis, positive family history, uveitis, alternating buttock, something that we just saw, asymmetric arthritis, and positive response to NSAID. The probability of diagnosis moves to 30 to 70%. Then comes HLA-B27, and then comes imaging. We'll have a look at these also. So how do we examine these patients now? Schober's test. What are we trying to examine now? Basically, we are basically looking at the flexibility of the spine. One, flexibility of the spine. Second, whether there is any involvement of the sacroiliac joint, some pathology of the sacroiliac joint. This is exactly what we are trying to see when we are examining these patients. The axial part, peripheral part, you can look for joint inflammation, you can look for enthesitis, you can look for dactylitis. But when it comes to examining of the axial skeleton, you will be looking at flexibility of the spine. If the flexibility of the spine is reduced, that is a indirect marker of seronegative spondyloarthritis. What will reduce the flexibility of the spine? There are two things that can reduce the flexibility of the spine. In acute phase, it is purely inflammation that can reduce flexibility. In a chronic phase, when there is fusion, when there is ligamentous calcification, that can also cause reduced flexibility of the spine. In the former, where there is only inflammatory involvement and reduction in the flexibility, it is reversible. In the latter, when there is fusion, it is not fully reversible. That is the difference between the two. So this is one, something that I'm sure all of you must be knowing, Schober's test. What we have to do, mark the L5 spinous process. The second line is marked 10 centimeter above. The patient is then instructed to flex forward, and difference between the two measurements. If it is less than 5, it is significant. Then there is a modified Schober's test. You draw a horizontal line at the PSIS. Second line is 5 centimeter below. Third line is 10 centimeter above. Ask the patient to flex forward and look at the difference between the line. Again, more than 5 centimeter is expected. Less than that makes it significant. Lastly, there is also a modified Schober's test. A horizontal line at PSIS. Second line 15 centimeter above. Patient asked to flex forward. You look at the difference between the two lines. Less than 5 centimeter makes it significant, shows that flexibility of the spine is affected. As I said, in the early phase, it could be purely because of inflammation. In fact, always remember, you may be asked by the examiner, what does this suggest? It suggests that there is reduced flexibility of the spine. Early phases, this is indirectly because of ankylosing spondylitis or seronegative spondyloarthritis. In the early phase, it could be purely because there is inflammation in the joints. When there is inflammation in the joints, the muscles, the paraspinal muscles go into spasm to protect those joints. And that's the reason why the flexibility is reduced. In the chronic phase, in somebody who has a chronic disease, it could be fusion of the vertebrae, calcification, which then leads to mechanical reduction in flexibility. One more bedside test that you can do, just ask the patient to turn to one side like this, lateral flexion sort of a thing. The rule of thumb is his finger should touch the knee or go beyond the knee. If it is short, that again is an indirect evidence that flexibility is limited. Chest expansion at the level of the nipple, the deep exhalation followed by complete inhalation, and you record the difference between the two measurements. It should be ideally more than 5 centimeter. Anything less than that suggest reduced chest expansion. Very important. What does this suggest now? If the chest expansion is, what does this suggest? It suggests that the chest expansion is less. Why is it less? See, in ankylosing spondylitis, this is the vertebra and these are the ribs. There are joints formed by the rib, the costovertebral, costotransverse joints by the rib with the vertebrae. In ankylosing spondylitis, there is one inflammation, and in chronic phases, fusion of these joints. If there is inflammation or fusion of the joints, the ribcage movement gets restricted because these joints are either inflamed or fused. Because these joints, the movement of the ribcage is affected because of fusion or inflammation, that's why the chest expansion goes down. So this is one more evidence of ankylosing spondylitis. So this is one more test that is based on this principle. Examination wise, you can have sacroiliac joint tenderness, which suggests that there is inflammation in the joint. There are a lot of other tests to look at if the sacroiliac joint is involved. I am sure you would have all these tests in your books. How do we go? One is distraction test. As you can see, the patient lies supine. The forearm is tucked under the lower back, so the lordosis is maintained and the lumbar spine is supported. There is a pillow placed under the patient's knees to make the patient comfortable. Examiner places the hand on anterior and medial aspect of the left and the right ASIS. You have to cross and do that with the arms crossed and elbows straight. And then you apply a slow and steady posterior force. As you can see this is what you are trying to do. And there will be pressure at the sacroiliac joints and the patient will complain of pain. So this is distraction test. Second, thigh thrust. Patient lies supine. The affected side hip is flexed to 90 degree. Pelvic is stabilized by placing a hand on the opposite ASIS. The examiner stands on the same side as the flexed leg and examiner provides steady pressure through the axis of the femur. This also can elicit pain at this. Now this can elicit pain in the hip joint, this can elicit pain in the sacroiliac joint, but this is one of the tests that you can perform. Thigh thrust, something that is very commonly used. Faber, patient lies supine and the examiner crosses the affected side foot over the opposite side thigh. Crosses the affected side leg with the foot on the opposite side, over the opposite side thigh. The pelvic is stabilized at the opposite ASIS with the hand of the examiner. As you can see this, a gentle downward force is applied, as you can see here, to the affected side knee of the patient and is steadily increased, exaggerating the motion of hip flexion, abduction and external rotation. Flexion, abduction, external rotation. This is what will cause again pain at the sacroiliac joint. So this is Faber test. This is something which is quite well known and you should know. Lastly, Jenslen's test. The patient lies supine with the affected side near the edge of the table. As you can see, it's near the edge of the table with the foot is dangling down. The patient's shoulders are positioned towards the middle of the table so that the patient does not fall down. The patient then draws the non-affected side into full flexion and holds the flexed knee. So this is the non-affected side. The examiner stabilizes the leg with the hand placed on the patient's hand here. You are stabilizing the other leg, and this is then pushed downwards. This is something that can again elicit pain in the sacroiliac joint here. The typical posture, as you can see here, this can either be in the early phase because of the inflammation. In the chronic phase, it can be because of fusion of the vertebrae. So always examine the posture of the patient. How do we diagnose it now? Now that we have had the history of the patient, we have examined the patient, how do we really diagnose it? What are the various investigations available? Role of HLA-B27. See, HLA-B27 is an important test, but 90% of ankylosing spondylitis patients will be positive for the HLA-B27 gene. 10% will still be negative. So it's not an all or none test. It's not that if somebody is HLA-B27 negative, it does not mean the patient will not have ankylosing spondylitis. So always bear that in mind. 10% patients are HLA-B27 negative. And the reverse is also true. Just because HLA-B27 is positive does not mean the backache becomes ankylosing spondylitis. Somebody with HLA-B27 gene may also have a prolapsed disc and have a mechanical backache. So you have to be sure that this is inflammatory backache. Only then getting a HLA-B27 make any sense. And even if it turns out to be negative, if it is inflammatory backache, we can go ahead with radiology to confirm diagnosis. Now, what in radiology? What is done? We have three common modalities available: X-ray, CT scan, and MRI. What do we look at the X-ray when we see the X-ray? One is X-ray of the SI joint, and second X-ray of the spine. That is what we see in ankylosing spondylitis. In X-ray of the SI joint, this is the SI joint, this is the sacrum, this is the SI joint, this is the ilium. So this is where the joint is located. In this, there is so much of sclerosis and fusion that you can't really see the joint per se. There is a grading called as modified New York criteria for ankylosing spondylitis. You can read this in the books. Most important would be, what do you see in the X-ray? Now let's have a look at this. See, this is the sacrum, this is the ilium, and this is the sacroiliac joint. You can see here, this is the sacroiliac joint. Here you can see more or less it is normal, hardly a little bit of subtle changes here, but more or less this is normal. You can clearly see the joint. That is very important when you see now. And there is not much of sclerosis. What do you mean by sclerosis? This white thing is sclerosis. It is generally called as significant sclerosis when this white is more than white of this area. Then it is called as significant sclerosis. So in this, it is just marginally more. That's also the reason why it is called as grade 1. There are suspicious changes, nothing which is very significant. Now look at this. This joint you can clearly see. In fact, this side, if you see, it's irregular. See, this is not a smooth razor sharp margin. Even on this side, see, it's not here if you see, it's a smooth margin. See, it's a smooth clear cut margin. On this side, see, this is a bit wavy. It's a bit, meaning it's not smooth. It is irregular. And again, there is sclerosis here. See, this area is more white as compared to this area. So there is sclerosis. This is irregular. What does this irregularity really mean? Is there are erosions. Possibly there are erosions here which are looking like irregular margin on the X-ray. Third, significant sclerosis and erosions. And multiple erosions actually can cause pseudo widening of the joint, because since there are multiple erosions, the joint actually starts looking wider. And lastly, ankylosis. You can't see the joint at all. See the previous one also that we saw, you just can't locate the joint. There is nothing that you can see. This is ankylosis. And along with that, you may also see changes in the hip joint. Okay. Suppose there are suspicious changes on the X-ray, you are really not able to make out whether something like, see this, now this, the patient has significant backache, X-ray is not really conclusive. You can go for a CT scan of the SI joint. What does the CT show? It can show the sclerosis very clearly. It can show the erosions very clearly. See, this is the sclerosis, and you can see clear-cut erosions. This is again very clear-cut erosion. So CT scan is generally used when there are doubtful changes on the X-ray. The best investigation is MRI of the SI joint. What does the MRI show? It shows clear inflammation in the sacroiliac joints. And this is something that can pick up inflammatory sacroiliitis clear cut. If it is bilateral, definitely inflammatory. If it is unilateral, one can have a differential between inflammatory versus infective. The other clinical features and investigations will help you reaching a diagnosis. Sorry, somehow I forgot to put the the X-ray of the spine. In X-ray of LS spine, or for that matter, whatever spine, what will you see? Early stages, you will not see anything. Late stages, you can see thin desmophytes or calcification of the ALL and the other ligaments. So, and when it is severe calcification, it forms a straight line, looks like a dagger, and that is what is called as bamboo spine. Now that we have the history, we have the examination, we have a few investigations, how do we diagnose? These are the ASA's criteria for diagnosis of seronegative spondyloarthritis. The ASA's criteria are available for axial spondyloarthritis as well as peripheral spondyloarthritis. So this is for axial SpA. How do you diagnose in patients with backache more than 3 months? Very important, more than 3 months, and age of onset less than 45 years. If the patient has obvious sacroiliitis on imaging plus one or more SpA feature. What are the features? Inflammatory backache, peripheral arthritis, enthesitis, uveitis, dactylitis, psoriasis, IBD, good response to NSAIDs, family history of SpA, HLA-B27, elevated CRP, then you straight away can make a diagnosis of SpA. Or the patient, there is no meaning, you don't always require imaging for a diagnosis. You can have HLA-B27 plus two or more SpA features, which can mean the features that we just saw. Okay, so you can diagnose it even without the MRI. This is axial SpA, and these are the criteria for peripheral arthritis. So either peripheral arthritis or enthesitis or dactylitis plus more than one SpA feature or more than two other SpA features. These are the core SpA features. These are the other SpA features. This is also what can give you a diagnosis of SpA. In recent times, there has been there have been changes in the nomenclature of axial spondyloarthritis. What we used to call as ankylosing spondylitis now is just a small part of the entire continuum. This is the continuum. It is axial spondyloarthritis. You have already seen it is involvement of the axial skeleton in spondyloarthritis. It is divided into non-radiographic stage and radiographic stage. What is non-radiographic stage? Patient has inflammatory backache. There is sacroiliitis on MRI, but X-ray does not show any changes. X-ray is normal. So this is non-radiographic stage, wherein MRI shows sacroiliitis, X-ray is normal. Then moves on to radiographic stage. What is radiographic stage? The X-rays now start showing changes of SpA. We already saw what changes are there. Once the X-rays start showing changes, then it is called as radiographic stage. Either now this stage also is without syndesmophytes, with syndesmophytes. So without syndesmophytes, the X-rays will show such signs suggestive of sacroiliitis, and then the syndesmophyte, wherein you will obviously see syndesmophyte. So this is how it is divided now. A patient of non-radiographic stage may progress to radiographic stage or may remain in this phase for prolonged period. So it is not something that this patient is going to get converted into radiographic phase at some point of time. What are the risk factors for conversion from this phase to this phase? Is uh, work that involves manual manual sort of a work, wherein it's a sort of a laborer who has mechanical pressure on the back, that work. Secondly, a high CRP. Third, smoking. These are the three risk factors which help or which lead to conversion from progression from this stage to this stage. Now that we have diagnosed, what is the treatment? So we will divide it into axial and peripheral because the treatment wise it is different. The first line of therapy is NSAIDs, particularly when it comes to axial SpA. In axial SpA, NSAIDs and exercises itself leads to remission in many patients. So first line is always NSAIDs with exercises. Do local steroids or steroids play a role? Definitely no role in the long run. Short run, yes. And if it is peripheral manifestation, peripheral spondyloarthritis, then local steroid in the joint can help. Disease modifying agents like sulfasalazine, methotrexate, they predominantly work for peripheral manifestations, not so much for the axial manifestation. So in axial manifestation, sorry, one thing that I forgot to tell you is it is this radiographic phase which is called as ankylosing spondylitis. This phase is not called as ankylosing spondylitis. This is non-radiographic expa. This is radiographic expa, which is called as ankylosing spondylitis, what we used to call previously. Sorry. So coming here, when it comes to axial manifestations, you give NSAIDs with exercises. If things don't improve, you straight away move on to the second line of therapy. Second line of therapy is either tofacitinib, JAK inhibitors, that is something that is not here written here, JAK inhibitors or TNF alpha blockers or interleukin 17 blockers. So once you have a diagnosis of axial SpA, you have definitive evidence, lab evidence for that, then the patient will receive at least 2 NSAIDs over 4 weeks. Not 2 NSAIDs at the same time, but one NSAID full dose at least for 4 weeks. If it doesn't work, second NSAID full dose at least for 4 weeks. If things don't settle, then you move on to the next treatment options. Somebody with peripheral arthritis, therapeutic trial of sulfasalazine, methotrexate, a local steroid if appropriate, with NSAIDs. If things don't improve, then we move on to the second line of therapy. There is a scale called as ASDAS, which is a scale that we measure. This is something like HbA1c for diabetes. That tells us how active the disease is, and many clinical decisions are based on this scale. So these are the ASAS ASAS EULAR guidelines for treatment of axial spondyloarthritis. So once you have diagnosed, if symptomatic, as we saw, they are started with NSAIDs to begin with, at least 2 NSAIDs, full dose, at least each NSAID for at least 4 weeks, and then you evaluate. If there is sufficient response, obviously you continue with exercises, not without exercises, physiotherapy and exercises, all the patients will get. If there is insufficient response, then you move on to the phase second, mainly peripheral symptoms, then you can consider glucocorticoid, sulfasalazine. If it is purely axial disease, this is where you start thinking in terms of JAK-I inhibitors, which would mean tofacitinib, upadacitinib, or TNF alpha blockers or interleukin 17 blockers. So these are the biologics that we use for this. And then you again evaluate the response for this. Peripheral, you can try sulfasalazine, methotrexate. If either contraindicated or there is lack of efficacy, then you again move on to either JAK inhibitors or interleukin 17 inhibitors or TNF alpha blockers. Thank you very much. If there are any questions, we can have it now.
Thank you, Shashank, for that excellent talk. I'm sure the residents who have attended will definitely benefit out of it. Right now in the chat box, there are no questions. So if anybody has any direct questions, you can ask. Okay, I think Shashank, you are a very good teacher. There are no doubts. So you have cleared all the doubts in your lecture. Thank you very much for sparing your time on a Sunday morning, and wish everyone a happy new year to come. And the next session would be on 25th of January. It will be taken by Dr. Jyotsna Madam, and she'll be speaking on scleroderma. Thank you everyone for joining. Thanks, Shashank.
Thank you.